how good are the available interventions and the recommendations that we have
For what?
For what we're talking about at the moment in terms of the hot flushes, the changes in libido or mood, these more acute things as a woman is going through the perimenopause, if she is one of those, I think you said 25% experience very little symptoms, but if she is one of those that is experiencing symptoms, does she have to experience those symptoms? Is that a given for her?
Okay, so there's a lot of talk about the perimenopause and the menopause. There are many women who actually don't have terrible symptoms in the perimenopause, but because their ovaries are intermittently working. And soon as they hit the menopause and their ovaries, their estrogen just drops through the floor, that's when their symptoms are horrible. So there is a variation as the timing of individuals. So let's talk about the postmenopause. A woman's ovaries have stopped working. Hot flushes, night sweats, vaginal dryness, sleep disturbance, anxiety, low mood. I'm saying low mood, not clinical depression. Estrogen is incredibly effective at alleviating those symptoms.
What's the difference between low mood and clinically diagnosed depression?
Clinically diagnosed depression is really continuous loss of the ability to find pleasure, to black mood. There is at least 2 weeks of severe down mood. Nothing makes you happy. You don't want to get out of bed. You can't communicate with people. It's profoundly severe. Now, it may be exacerbated by the menopause, but before you just throw hormones and say that you should be responding, there are people with clinical depression who are not going to get well with hormones, and so it's a very important thing that if mood doesn't improve with hormones, then you need to start looking at other more profound depressive illness. But moving away from that, low mood, just not feeling, women will say, I've lost my mojo. I'm just not as happy. They're not getting out of bed. They're just saying, I'm just not happy. I'm not laughing as much. I'm anxious. I'm irritable. That's very responsive. Now, and that's fairly straightforward to treat in most circumstances. But when we're talking about the perimenopause, women are intermittently making an egg and having their own bleed. And the hormones are going up and down. So one day the estrogen is extremely low and the next day it's extremely high. One day they're sweating and the next day they've got sore breasts and bleeding. If you give standard HRT to that patient, on the days where their estrogen's high, you can actually make it worse.
Right. So it's much harder to intervene if it's being very volatile.
Yeah, and you can actually worsen symptoms.
Does that happen? Would anyone prescribe at that
Well,
phase
some
of
people
someone's
do,
life?
and you can actually, in the old days we used to, and we used to find we often make symptoms worse. And what we also do is we cause the onset of a bleed with our artificial regimen, and then they ovulate and have a bleed. And then they're bleeding and not bleeding, and then they don't know when they're bleeding. And so and also at this time, women often need contraception. So a common practice in Australia is to give a low-dose oral contraceptive pill. And we're very fortunate that we have contraceptive pills here that contain the identical estrogen that we give as HRT. So there's a whole range of things we can do that will give cycle control, contraception, and symptom relief that is not yet HRT.
Right. Okay. So perimenopause, different set of interventions
Yes.
than the post-menopausal period.
Yes.
Phase. And just to kind of, I guess, umbrella everything we're talking about here, it seems like there's kind of two big buckets. Correct me if I'm wrong. You have those more acute symptoms that we're thinking about, trying to manage to make that woman's life more bearable, enjoyable, quality of life going through it. And then there's also we're forecasting out. So we spoke earlier about it's not natural to necessarily be living to 80 to 90 as a result of going or reaching menopause, being in the postmenopausal phase. these changes in hormones can predispose you to risk of different chronic conditions. Can we kind of just further define that? What are those chronic conditions? You sort of said estrogen goes off the cliff. So if a woman's listening and she's one of those that's fortunate not to have the acute symptoms, so thinking, okay, well, I got lucky, I'll just go through, I don't need to worry about any type of intervention. What I'm hearing is, well, actually you'd still want to pay attention, because even though you're not experiencing symptoms, your hormones have changed and you could be placing yourself at increased risk of certain conditions later in life.
Before we get there, though, you do need to be aware that a lot of women think, oh, these symptoms are terrible, but I don't need to take anything because they'll be gone in 6 months. 42% of women aged 60 to 64 are still having hot flushes and night sweats. So although we describe them as acute, those terrible symptoms can last for decades. I see patients in their 70s who are still having hot flushes and night sweats.
And just assume it's normal.
Although they just think it's terrible, but they
have to put up with it.
Or we treat them for it. But
right.
But what I'm saying is, for many women, the symptoms are, the average duration of symptoms is at least 7 years. So if a woman's having bad symptoms, a woman shouldn't think they're just going to go in a few months, because they're probably not just going to go in a few months.
That's a good point.
But for the woman not having symptoms, the changes that occur at menopause is bone loss. So even a woman with no symptoms, on average, women lose about 6% of their bone over that 2 or 3 years of transition.
Is that primarily because estrogen falls
Because
off the
estrogen
cliff?
is falling.
Right.
Women's cholesterol levels can change, so their cardiovascular disease risk changes.
As in it goes up.
It goes up. Women overall don't tend to gain weight, but even if without any weight gain, women tend to accumulate central abdominal fat. When you accumulate more fat around your tummy, that's bad fat, which is associated with inflammation, cardiovascular disease risk, diabetes, and some cancers, including breast cancer.
So is that, again, that's hormone related?
Hormone dependent.
Right.
So on average, women increase their central abdominal fat by about 20 to 40%.
You wrote a paper on that, right?
That we've described that, but there's actually studies that have specifically shown that that's not my research, that they've used techniques to actually show changes, doing scans annually across the transition and showing how much abdominal fat there is. And women's risk of diabetes goes up. So estrogen has incredibly important actions in terms of metabolic health and how insulin acts in the body. So when estrogen levels drop, women become more resistant to the effects of insulin, and so their risk of diabetes increases.